So many of the past and ongoing studies have shown the need for joint line restoration for optimal knee kinematics following a TK. However, many of these studies highlight the role of joint line restoration in revision total knee arthroplasty. Also, the acceptable limit of joint line elevation for an optimal outcome has been ranging from 4 to 8 millimeters in various studies. There are also contradictory studies has also been reported in the past, which have found no effect of joint line elevation on quality of life or clinical outcomes. With this background, we did our study at a tertiary care hospital to analyze the magnitude of joint line elevation after primary total knee arthroplasty, examine the effect of joint line elevation on postoperative outcomes, and to propose a cutoff limit for joint line elevation that would give an optimum functional outcome. We retrieved data from an electronic and physical database of patients undergoing primary osteoarthritis for TKR for primary osteoarthritis with a minimum 1 year follow-up. We excluded patients who underwent TKA for a complex primary in the form of post-HTO or a malunited fracture, revision total knee arthroplasties, rheumatoid cases with a pre-op flexion deformity of more than 20 degree, and those patients who denied consent. Assessment of joint line position on preoperative radiograph were done by 2 independent observers on the basis of anatomical bony landmarks excluding the osteophytes, and we measured the median epicondyle joint line distance, the lateral epicondyle joint line distance, and the fibula head joint line distance on a standard AP view of the knee, true size with the patella centered to the femoral condyles. All the patients were operated by a single senior orthopedic surgeon using a median parapatellar approach using the PS implants, and the patella was resurfaced in all cases. Intraoperatively, we used the wide size line and the transepicondylar axis, which was encouraged. Standard postoperative mobilization and rehab protocols were ensured, and the patients were followed up at 1, 3, 6, and 12 months. Now, at 1 year assessment, the functional outcome scores were assessed in the form of WOMAC and KSS score, again by an independent observer, that is a physiotherapy resident. The radiological assessment was again repeated to calculate the median epicondyle, lateral epicondyle, and the fibula head joint line distances. As the poly is radiolucent, we used the lowermost part of the femoral condyles in this, and the post-op X-rays as a reference. Scanogram was done to know the hip knee ankle axis. So our results, we studied 120 patients with a mean age of 67.37 years, and which include 46 males and 74 females. In our study, we found the joint line was elevated in 104 patients, although 16 patients showed a normal postoperative joint line. There was no patient with joint line depression, and the mean joint line elevation was around 3 millimeters. Our results show that there was a falling trend in the KSS score and a rising trend in the WOMAC score with every 1 millimeter rise in joint line elevation. This difference was found significant at a range beyond 5 millimeters. So now we divided our patients into 2 groups, Group A with less than 5 millimeter joint line elevation, including 98 patients, and Group B, 22 patients with more than equal to 5 millimeter joint line elevation. These 2 groups were matched with respect to the age and the preoperative range and the postoperative mechanical axis. And on comparison of their functional scores, we found that the KSS and WOMAC scores were statistically better in the Group A with less than 5 millimeter joint line elevation as compared to Group B with more than equal to 5 millimeter joint line elevated. So we conclude that joint line elevation is a common occurrence and has a negative impact on postoperative outcomes. Any elevation more than equal to 5 millimeter from the pre-op value results in poorer outcome, and appropriate pre-op and intra-op assessment of joint line with the help of bony landmarks should be encouraged for optimum restoration. Certain intraoperative tips in the form of removing lesser amount of femur guards, especially in cases of bone loss, removing posterior osteophytes so that they do not tend the posterior capsule and reduce the flexion gap, appropriate position of the femoral component and use of distal and posterior femoral augments, especially in cases with bone loss, should be encouraged so as to restore the joint line as optimally as possible. Thank you for your patient listening.